time. Dr. Jenna Parton is here. And also Dr. Galletly joining us. And we are going to be talking about your health, your well-being, and hopefully unpacking, as I was talking to Jenna earlier, the ads that are now out on the internet and the radio reminding us about colon cancer and who gets screened. And according to the latest ad that I heard yesterday, I'm well overdue for a screening by at least 12 years. So I'm getting nervous because it said every hour your health is more at risk. So that's where we're going to go this week on the podcast, and I'm looking forward to diving into the conversation. Jenna, it's great to have you back.
Thank you for having me, James.
And we're not online.
We're not. What do you mean we're not online?
We're in the same room. We're not recording online as we usually do. I mean, we're coming to everyone online, but recently, we've been recording online.
James, I'm hurt. This is the hat trick of us being together recently. This is third time round.
You know how many shows we've done Zoom? We were going to do a Zoom last week, and then we didn't. All right.
Yeah, no, I'm here.
Okay.
And I think we should also just check. Did you pronounce Dr. Neil's name correctly?
No.
The Neil said it pretty good.
The Neil, like I'm not a the Irish pronunciation is definitely happening.
So it's not Irish, it's Scottish. We have been informed of it.
Irish. Okay, go on.
Yeah, okay. So it's Neil Galletly. But
did I say that?
You kind of missed the whole G thing at the end. But listen, everyone calls me Dr. Neil. That's just fine.
But it's worth mentioning in case someone tries to Google you. That's all.
Oh, that's true.
That's why I typically just go with first names.
Yeah, but I quite like it here in Dubai. They do tend to just call you Dr. Neil. Imagine back at home. I mean, patients are screwed. Can I try and see Dr. I'm not even going to try.
It is a weird thing, isn't it? Like just the way we've dropped all family names in the UAE and the Middle East for the most part. We just go by first names. It's kind of cool.
I prefer it personally, but that's because I've always had not great surname. Doesn't really suggest, it's not got great connotation. Burton, and from where I'm from, it's Ben. So yeah, so Pikeway's cool. Galletly.
Yeah, no, if you can say it, it's cool, but Dr. Neil's so much easier. And I think it feels a lot more personal using people's first names. It's nice.
And so I'm curious. So let's jump right into colon cancer and all things to do with that part of our bodies. This is the time of year, and I actually just said, it's colon cancer month, right? Or screening month, or I'm hearing all the ads. So
there's a month for everything, James.
There is indeed a month for everything, but yeah, March is for most of the world colon cancer awareness month. So in the US, in Canada, in Europe, it's colon cancer awareness month. Now the UK, we like to be slightly different. We probably saw that the Europeans had chosen March, and we're like, no way, we're not doing that. So confusingly in the UK, bowel cancer or colon cancer awareness month is in April. So if you're listening to this a few weeks later, well, you're still in bowel cancer awareness month, so that's great. And I think in Australia, it's kind of because it's all upside down now. It's in the summer sometime, but yeah.
I wonder who decides what month is which.
I don't know. I'm wondering who decides. Do we go with bowels? Do we go with colon? Who's deciding which part of the world we're going to use which nomenclature? I mean, that alone is an entire podcast. But it's at least we got a month. At least it's shining the spotlight for a month, because I get the sense, and Jenna, you can help verify this as well. But I get the sense that when we talk about bowels and colons and cancer, put those two words and that other word together, people kind of zone out and say, I don't want to think about it. I don't want to deal with it. I don't want to have a conversation about it and just carry on with their lives, hoping that everything goes okay.
Well, I think you're absolutely right there. It is one of those topics that's kind of not talked about. It's a polite dinner table conversation, isn't it? So it is really important to have that awareness month to kind of get the message out there. But, also remember, colons are for life. They're not just for March. So it's something to be aware of the whole year round.
But it's funny because we talk so much about breast cancer and lung cancer, and yet colon cancer is one of the big cancers, and it does have, I don't want to say a high death rate, but sometimes it can present quite late, especially if it's on the right side of the colon. And yet people aren't quite as aware of it as some of the other cancers. But yeah, it's its prevalence should mean that it is something that is talk about screening more regularly.
So what are we looking for? Like how, at what age should I really start being concerned, and what are some of the signs, symptoms, etc., that I need to keep on mind?
Sure. So colon cancer, it's like many diseases, it gets more common the older that we get. And traditionally, we've talked about needing to start screening, start being increasingly aware from above the age of 50. Now, depressingly, there seems to be increasing numbers of cases in younger adults now. And so a couple of years ago, the US recommendations changed. So now they're recommending that everyone from the age of 45 starts thinking about colon cancer screening. Here in the UAE, the local population has got a high incidence of colon cancer at a younger age as well. So in Dubai, the guidelines are starting at 45. In Abu Dhabi, the guidelines are actually saying at the age of 40.
Wow.
So it is something that is getting depressingly more common in a younger age group that you wouldn't have thought was associated with that sort of disease.
Why? Sorry, James, to cut in, but why do you think the UK is so late? The UK is so delayed. It seems like they tend to screen much older populations, and they certainly don't have anyone in the 40s being screened routinely. That is obviously it's got quite a strong genetic predisposition. But for those general member of the public, it seems to be screened a little bit later. Like, why do you think that is?
So, I think a lot of it is about resources and about being able to deliver a screening program effectively. It's fine saying, right, that's it, we're going to offer everyone above the age of 40 a colonoscopy every 2 years. But if your health system doesn't have the resources to be able to do that, then you're just setting yourself up to lose. So the UK has actually, I think, taken a really pragmatic view, and they initially started screening, I think, at the age of 55. And then each couple of years, they're kind of whittling the age down and down and down as the ability to screen increases. But remember, the screening program, this is an additional workload on top of the already busy workload of gastroenterology departments, everyone coming for a colonoscopy because of symptoms. You've then got to fit in this big cohort of people that need screening. So, I think the UK, given it's a somewhat resource-limited healthcare system in the NHS, they've taken a very pragmatic view of saying, right, okay, what can we achieve? Where can we do the most good? And as the ability to screen has increased, the age range for screening has increased as well.
So what are some of the signs? I mean, if we're starting in the local population here in the UAE and different parts of the world, as early as 40, starting to screen for colon cancer, what are some of the signs that we need to be keeping our eyes out for that might even be pushing me towards going to get screened?
Well, so of course, what's important to realize is screening, we're talking about people who don't have any symptoms. If you're waiting until you've got symptoms, that's not screening, and it is potentially too late. But if we're talking about the sort of symptoms that you can get from colon cancer, the sort of things you should be looking out for and having a chat with your GP or your gastroenterologist are if you're seeing blood when you go for poop, if you're seeing a change in your toilet habit, if you're always a once a day kind of guy, and now you're going 2 or 3 times a day, and that's been going on for a few weeks, well, that's a change that would be worth having a conversation with your doctor about. Again, if you're getting persistent tummy pain, that's something to come and have a chat about. If you're losing weight unexpectedly, and goodness me, we're all keen on losing weight, but it's dropping off unexpectedly, then that's another thing to come and have a chat about.
I love the idea that we go and get screened, and are we talking yearly screening is what is being recommended, especially once you reach, depending on the age, let's say it's a 45, 47 age group, once a year you should be going in and getting screened. Is that the protocol?
So I think it all depends on the screening modality that you choose, because there's different ways of...
Oh, there's not one size fits all?
No, absolutely.
Yeah, actually, it's a good point, and I'll let Neil take over in a second, but a lot of people get really nervous about screening because they think someone's going to touch them, go near their bowel, have to have some sort of intimate examination. And sometimes that's appropriate, but the majority of the time, screening doesn't involve that at all. And I'll let Neil carry on.
Realize that.
Which I think sometimes puts people off.
Yeah, for sure.
No, I think you're right. So probably the 2 main ways of doing screening. are you can either do a poop test every year, and what we're looking for in the poop test is microscopic hidden traces of blood. Way too small for you to see, but if you've got an early growth, either a polyp or an early cancer in the colon, they can just shed a few drops of blood from time to time, and this really sensitive poop test will pick this up. So one really good way, really effective way, not particularly invasive way of screening is doing a poop test every year, looking for hidden traces of blood. Now, the downside of that is if you get a positive result, then you'll need to go on for possibly a more invasive test. Now, the other recommended way of screening is with a colonoscopy, and that, of course, is invasive. It involves looking inside the colon with a camera. And we can probably talk a little bit in a few minutes about colonoscopy, demystify it a little bit, take away a lot of the fears of colonoscopy, but of course it is still more invasive than doing a poop test. And doing a colonoscopy, it allows you to have a really, really good look on the inside of the colon. You can find, and also, this is really important, remove even the tiniest polyp from the colon. We think pretty much all colon cancers start life as small polyps. So if you find small polyps, you remove them, it stops them ever from having a chance in the future of turning into something. And so that's why colonoscopy is such a good screening tool, because you're not only looking for a problem, you can also deal with the problem. And by removing polyps, you can potentially prevent cancer in the future. So that's why colonoscopy is a good screening tool. But if you have a colonoscopy and it's all clear and you don't have a family history of colon cancer, then you're good for about 10 years.
Wow.
You can forget about it, you can stick your head in the sand for a good 10 years.
I didn't realize that. That's pretty good.
Mm.
Now,
Can I also
Yeah.
just say that we should talk about what polyps are, because there'll be a lot of people listening that are saying, what actually is a polyp?
Yeah.
And it's
we hear the word.
but what do you know what it is?
Yeah, I mean, I've seen the pictures, so I've got an idea.
Yeah.
But generally speaking, again, it's one of those words that, in a sense, I get the feeling there are different things polyps can be, or they can be different growths and placements and all sorts of things.
They can occur in the bowel, and there are 3 different types of polyps. Some are more likely to go into cancer than others. Majority of them are they almost look like a mushroom, I suppose, on the bowel, and they're non-cancerous, but they are a tumour. So they're a tumour, but they don't have the ability to start spreading and going into the bowel and sort of spreading around the body. However, they are a precursor. So usually if you find a polyp, as Dr. Neil said, you will tend to remove them at the time that you find them. So they have the ability to become a malignant cancer in the future. And I heard a statistic that about 95% of colon cancers tend to start out life as a polyp. And I think you mentioned as well that you said even more so.
Yeah, no, absolutely. It's probably about 95% that we think. And yeah, polyps, they're as Jenna said, they're like little, initially benign growths on the lining of the colon. They can look like little warts or like little mushrooms. And probably, only 2 or 3% of polyps are going to carry on growing if you leave them in place. And potentially, over a long period of time, we're talking around 10 years or so, grow from this tiny polyp into a colon cancer. And that slow growth rate is why if you have a normal screening colonoscopy, you're good for 10 years because these things grow slowly. You don't need to be having these tests every year or so.
And removal, as you said, if you're in for colonoscopy, the removal process of these polyps is fairly straightforward.
It's, for the vast majority of polyps, is very, very straightforward. They're removed routinely as part of the procedure. And that way, if it was one of those polyps that might carry on growing, it's gone. It's not going to grow anywhere.
And then, of course, you test them.
And then, of course, we test them. And, unless the polyp is over 2, 3, 4 centimeters in size, it's almost certainly not going to be cancerous. So what you're testing them for is to see if it's the sort of polyp that is potentially precancerous. As Dr. Jenna said, there's a few types of polyps, and what we're wanting to look for and remove are the ones that are potentially precancerous, that have that small percentage of chance of growing and growing and growing over time.
When we speak about colon cancer, is everyone pretty much susceptible to this? Is this something that the older we get, the more likely we are to get polyps, the more likely we are to start to develop some that could be cancerous?
So pretty much so, James. I mean, if you've got a colon, then you're susceptible to colon cancer. It's as simple as that. And the risk tends to go up with age. There's certain people, they have a higher risk. For example, if you have a strong family history of colon cancer or colonic polyps, that's going to put your risk up a bit. But everybody, if you've got a colon, you're at risk. You're at so-called average risk. And so you should be participating in a screening program, certainly from the age of 50. But as we spoke about earlier, maybe considering starting at the age of 45.
There are things you can do to moderate your risk. I mean, for some people, they will go on to get cancer. It could be because of family history or because they're just that unlucky person. However, if you smoke, if you are obese, if you have sort of generally lack of healthy living, so you're not particularly active, if you're someone that consumes a lot of red meat, because as the blood in red meat breaks down, actually creates like a carcinogen within the colon. So people that have consumed high quantities of red meat and people that have got a low fibre diet as well, these make it's considered a risk factor anyway for you're more likely to develop colon cancer. It doesn't mean you will. It doesn't mean that you won't by sort of avoiding them, but it is something that will make it more likely for you to go on to develop.
So I mean, that's our goal then, right? Is to have the better diet and to try and mitigate those factors that could manifest later on in life.
Yeah, I think people always want to have, right, so if I do this and I do this and I do
That's
this,
what I'm thinking.
I'm definitely not going to get colon cancer. And that's just not the case. If you're somebody with a first degree relative who had colon cancer, especially if they were younger, then it's worth having a chat with your doctor, because potentially you're someone whose screening might need to start a little bit earlier. You might just need to have the symptoms of colon cancer a little bit more in your foremind, because it's something that's more likely to happen to you.
Yeah.
But yeah, I think everything we talk about, James, always comes back to a healthy diet, exercising regularly, trying to keep your weight relatively neutral. All these things help to sort of ward off many different things, but it doesn't mean for definite that you're never going to get anything. And of course, you might just be that unlucky person that gets the sporadic cancer that just occurs, and you've had polyps, you've not known about them.
I mean, that's a scary thing. I mean, obviously, listening to our bodies and watching and paying attention to change can help to indicate, hey, I need to, it's great. Because as opposed to ignoring it and then waiting down the road and finding out, oh, if you dealt with this earlier, you wouldn't be in the situation you're in now. And that sounds to me like the typical cancer kind of issue is, just pay attention and just let it go.
And and then it's the big tragedy of colon cancer, because a lot of cases can be prevented. That diet and lifestyle can certainly make a difference. Participating in screening programs has definitely been shown to make a big difference. And colon cancer, even if you find colon cancer, if you find it early, in the earliest stages, over 90% of people will survive. So it's eminently treatable. But the tragedy is that once colon cancer has been there a while, it's started to spread through the wall of the bowel, it's started to spread elsewhere in the body, then your chances of survival are significantly less. And this is true not just of colon cancer, it's true of any cancer, it's probably true of most diseases. The sooner you find them, the sooner you intervene, the sooner you make a difference is so important.
We should also just mention too that we've talked about how blood loss can sometimes suggest that you might have a cancer that's present. And obviously it's always worth talking about any form of blood loss with your doctor, because sometimes it could just be something quite benign like hemorrhoids. But if you have blood that is mixed in with the stool, that means it's something that will warrant further investigation.
Would you be able to see that? I mean, if it's just you've got microscopic amounts that you test for with stool tests, okay, because you can't see it. Unless you've got a whole bunch of blood, I'm thinking, you're not really going to see that blood, are you? I mean, and how many people inspect their poo anyway? That's the other question, aside from me.
You'd probably do, but well, people do see it because people do present after it. So, and it also depends, there's a varying amount as well. And sometimes people can even describe like a little bit of bleeding in between stools, which is, again, that's really not normal. But usually the typical is somebody will describe that they've seen it in the stool, or they've wiped and they've seen something. Again, could be hemorrhoids, but it could be something more sinister. And the other thing to mention is you can get cancer in different places of the bowel. And sometimes if it's quite early in the colonic tract, that you can actually start to break down and digest the blood. And your stool can present almost like a charcoaly type black colour.
So let me interrupt this. How large is the colon?
It's large. You'll know this. I can't remember.
Because I'm just thinking a colon is a small part of the end of our digestive tract. But
Okay, so your colon is called the large intestine, but it's not the large intestine because it's long. I mean, in terms of length, your colon's probably about 80 centimeters or so. So it's not super, super long. It's called the large intestine because the diameter is bigger. And then, if you think back to any anatomical drawings you've seen, there's that kind of long squiggly bit in the middle. That's the small intestine, which is narrow in diameter, but is long. It's meters and meters long. And that's where kind of all your absorption of nutrients and goodness happens. And then, once all the goodness has been taken out, the poop goes into the colon. And really the job of the colon is to kind of take water out of the poop, is to compact it and get it ready for expelling.
Okay. So then you're talking at the start of the colon, as it's removing water and such, then you might not even know.
Yeah, the more typical history is a dark type stool would suggest that there's bleeding higher up the GI tract, like the stomach, for instance. But it can happen a little bit in the colon as well, especially if it's sort of on the right-hand side of the colon. And it's just worth noting because people always think if there's blood in their stool, they're always looking for fresh red blood. And yes, that is absolutely the case.
That's exactly what I was just thinking.
Yeah, and it is the majority of the case of colon cancer. But if you have a dark charcoaly type stool, we often say it's like almost like a soot type colour, and it's often quite sticky in the pan, and it would look different. It would look different to what you would normally have. Then that warrants a visit to the doctor, whether it's colon cancer or whether it's it could be something else. You can have a bleeding ulcer that's further up in the GI tract, but also worth noting that is also blood.
Is there any indication why we're starting to see this issue happen in people as they're younger? I mean, right, even in their 40s, it just seems so young to be experiencing this condition.
It does, doesn't it? And it's quite depressing. We think it's probably a lifestyle thing. We probably think it's probably a diet thing. As Jenna alluded to earlier, there are a lot of lifestyle things that make a difference. One thing that maybe she didn't mention, processed food, your burgers and so on, they're particularly kind of big no-no. As with anything, you've got to take things in moderation. So we're not sitting here saying, right, that's it, no steaks, no burgers for the rest of your life. But we're saying don't go out to McDonald's necessarily every evening, just moderation.
I think that's what myself and James talk about a lot, isn't it?
It's all moderation.
Yeah, it's about if you try and do something to the extreme, it's not going to last. And also, what kind of life is that to live as well? So yeah, it's just everything in moderation.
One of the things we spoke about is you go in and you have an internal exam. As soon as someone says, okay, you're gonna have to drink this stuff, we're gonna clear everything out, and then we're gonna put a tube up there with a camera, and hey, if we see any polyps, we're gonna take those out too. People kind of go, exactly the face you just made. It's like, yeah, I don't think so. Yet, it's so important.
It is important. And I think there is a lot of fear out there about the thought of having a colonoscopy. When I see someone and explain to them about the procedure, I always tell them the worst bit is the day before. The test itself is easy. But the day before, honestly, it is a little bit miserable for two reasons. First of all, you have to be on a liquid-only diet. And having done it a couple of times, I can tell you that gets really boring really quickly. But it needs to be liquid because you need to be flushing stuff through. Yeah. The cleaner it is, the more your doctor can see, and so the more valuable the test is for you. And then just to add insult to injury, the afternoon or the evening before the test, we make you drink this kind of big jug of dynamite that makes you go to the toilet a whole bunch of times. And again, the cleaner you are, the better the test is. So that's the most miserable bit about it. It's not awful, but it's not so much fun. The test itself is easy. You come along to the clinic or the hospital and you get given medicine in the vein that'll put you into a nice deep sleep. Technically, it's not a general anesthetic, but for all intents and purposes, it feels the same. You go into a nice deep sleep, and while you're snoring gently, then your gastroenterologist gets on and has a gentle, careful look at thin, flexible camera, goes inside with lots of lubrication. Your gastroenterologist is going to steer it gently all the way around to the beginning of the colon, and then just pull it back inch by inch, centimetre by centimetre, looking behind all those folds, making sure that there's no polyps, no growths, and as we spoke about earlier, removing them if we see them. And most colonoscopies will typically take about 20 to 30 minutes.
That's really fast.
Yeah, exactly. It's not a an all-day thing. It's a pretty quick procedure, but you'll be blissfully unaware of it. Then after the procedure, you wake up again, you get fed and watered, and goodness, you're going to be feeling a bit hungry by then. And the gastroenterologist will be able to explain to you exactly what they've seen, exactly what they've done.
Show you the video.
If you want, yeah.
Do you know what though? I think the problem at the moment is it's time. People are so busy, and we often talk about screening, go visit your doctor for this, and people are just so tight on time. They've got so much on their shoulders. Maybe they've got children and a job, etc. It's so hard to say, right, okay, I know I need to go for this colonoscopy. I need to set aside that day before for the bowel prep, and I need to set aside the morning after. Well, it's really the whole day because you have to recover from the sedation that you've had during the colonoscopy to do that. And it's hard to get over to patients. Look, it's a small thing to do, and I appreciate the time is tight, but it's so valuable and so worth it.
It's one of those things you got to plan in.
Yeah.
But that's true. But remember, as we said, you're good for 10 years after this.
Yeah.
So that 10 years, does that also count, say you're in your 50s and you're going for this? So it's 10 years from whenever you do one?
Yeah, as long as your colonoscopy is completely normal,
Yeah.
and you don't have any extra risk factors, you don't have a strong family history, then you're good. Now, if you have a colonoscopy and maybe you find 1 or 2 small polyps, then we probably want to bring you back in 5 years.
Okay.
If you do a colonoscopy and we find kind of 20 polyps there, then you want to be coming back in a year, but you'll kind of realise if you've got 20 polyps growing there, you'll want to be coming back in a year's time.
So these polyps actually grow pretty slowly.
Yeah.
Which that's a good thing.
That is definitely absolutely, and that's that. It's great that you've got this big window of around 8 to 10 years to intervene.
We talk polyps. Is it possible to have colon cancer without polyps, but you notice there's infection, or infection is the wrong word, but you notice abnormalities in the wall of the colon? Is that also possible?
It's possible, but honestly, it's pretty rare.
Okay.
The vast majority come from polyps. Now they can be, rather than looking like a great big mushroom, they can be very flat polyps. They can be a little bit more difficult to detect, and that's why you want your gastroenterologist to be taking a really careful look while they're doing their procedure, taking their time, pulling the camera out. Now, interestingly, artificial intelligence is all the rage in medicine at the moment. And there's some really good artificial intelligence tools for colonoscopy that will kind of basically make a nice little ping sound and draw a little box around anything that it sees as a polyp. So you've got these really great tools for helping you identify even the subtlest, flattest of polyps, and sort of to increase the chances of everything being spotted and removed.
That must take the pressure off you a little bit as well, because there's so much focus on you being able to identify everything. It must be quite an intensive 20 to 30 minutes during the colonoscopy for the doctor that's there as well. So it must be great to have that almost backup, or another, it almost feels like another pair of eyes.
Well, I think having a second set of eyes, as it were, where there's really good evidence that does increase the yield of polyp scan. It does increase the benefits of doing the test. So yeah, it's a really useful thing. It's still pretty much in its infancy, but I'm sure that in 2 or 3 years, pretty much every endoscopy centre will have kit like this, and they'll be offering that.
Have the tools of the trade changed much in the last few years, or is this, when we talk about the endoscopy scope and tubes, and it's pretty much stayed the same?
So I guess what's changed is the optics.
Okay.
Back in the old days, doctors were kind of peering down the scope, looking down these fiber optic cables, which more often than not had started to break, so you weren't getting very clear view. Everything was looking really fuzzy. But over the last 20, 30 years, the advancement in the optics is amazing. And now, you're getting ultra high definition cameras. You're seeing incredible details of what's going on through the endoscopy. So I think that's the key change, the optics that we've got there. And there's little clever techniques where you alter the amount of blue light or red light or whatever in the light that is being reflected off the colon tissue. that helps you identify structures in a little bit more detail. And then, as we spoke about, we've now got the AI tools that help us identify things. So I think the main changes over the last 10, 20, 30 years are about the optics, about the visuals, about these incredible images that we can now get to help us see what's going on.
And do you find people are more attuned to be thinking about this in the, especially in the last 10 years or so? Going and getting a screening before there's some reason to have it, so they're feeling fine when you go get screened. Do you find this happening more often now than it did in the past?
Well, I guess the advantage of having these yearly awareness months and being able to talk like this is about increasing awareness. And I think there is slowly increasing awareness of this, but still, there are too many cases of colon cancer being caught late, and there's still a lot more work that we can do.
I feel like in Dubai there's only two types of patients. No, it's so true. There's either the patients that you can't get in, can't get in to get checked, they're too busy. You maybe do some blood tests and they might come back in 6-7 weeks despite many phone calls for their follow-up and to discuss their blood results. There's actually a patient I'm trying to track down now, which I can't even get hold of her. So some patients, it's really hard to get them in and come and get these screenings. And then there's the patient that you have to actively talk out of having the procedures because they really don't need them. They had it last week. Everything was clean, crystal clear. You don't need to go back. Yeah. So I find like patients seem to be on such a wide spectrum, and you get very few that are sort of in the middle.
I love the demystification that you don't have to go through the invasive process yearly necessarily. If everything is fine, and I get the impression that that's for most of us, then you got a 10-year window.
Exactly. And, again, about the demystification, I think it's the fear of the unknown of for any medical test, particularly ones that involve tubes going up your ass.
Exactly.
And, I say to people, I explain all this and say, but only once you have the test will you realise, and then you'll be fine next time. But it's getting over that kind of mental hurdle of saying, okay, I'm going to go through it. And then you realise, actually, it wasn't that big a deal. I'm really glad I did it. I'm really glad for the reassurance. Because I think it's natural. We all worry about what's going on inside. And, oh my goodness, the things that we can't see, what could be growing there, what could be going on. So I think there's a huge sense of relief, a huge kind of weight being lifted off people's shoulders when they come, they have the test, and they tell them, listen, you're all good.
And the whole hereditary thing is another flag that goes up. And obviously, if you've got polyps in the family, go and get checked. It just makes sense. Men more than women, women more than men, is it gender neutral when we talk about colon cancer?
It's pretty much equal opportunities.
Okay.
There's maybe a slight preponderance in men, maybe because we kind of have those better lifestyle habits with the red meat and so on. But there's not a big difference. Unfortunately, colon cancer affects both sexes, and definitely everyone should consider screening them.
The fact that it's earlier ages, that is just alarming to me. That's something I didn't realize. I hadn't been paying attention.
It's just even from a personal perspective, I've known quite a large number of people in their 30s with colon cancer, and some have lost their life. Yeah, and that's not looking at just statistics. I am aware that it's becoming more prevalent in the younger ages, but that's just from a personal perspective. And you think, gosh, it's really sad. Some of them have had family connections of people that have also had cancer in their family, and others haven't. And it's just, it's sadly, it is a byproduct of the modern world that we live in.
If you had to make the pitch, for people to get screened, to get this on their mind, to be talking about health of colon, what would it be? What's your pitch?
It's, I guess it's emphasising that this is a potentially preventable disease. If you come in and see a doctor, a few simple tests, we can prevent problems in the future. So don't ignore it. Come in, get looked at.
It's preventable. That's the key thing. It's preventable. That would be the real kick in the butt, so to speak, is if you hadn't gone and been screened and then you found out that this was an issue and you could have prevented it.
It'd be a bad day.
It would be a very bad day. Yeah. It's been a lot of fun. This has really opened a lot of doors for me.
And we should mention where you can find Dr. Neil.
Yeah, at Health Bay Clinic. Do Health Bay here in Dubai. we'll put the number into our description of the show, unless you know it off. You got it.
No, I never called this.
Yeah, but Health Bay, great service provider here, great place to go. So, and go and have a chat with Dr. Neil. We've had a great conversation right here. And what you hear is what you get, or what you see is what you get. We're also on YouTube. So, anything you want to round off with, Jen?
We've covered everything, James. What were you expecting from me at this stage? I think the thing to say is, if you're unsure, go and see your doctor. Dr. Neil's in Health Bay on our Wasl Road. Always worth having a conversation. You don't lose anything from a quick appointment, so just go.
And if you, sorry.
And absolutely, and it's this conversation. When we were in my colonoscopy kit the first time, you just want to have a chat about things. That's absolutely the thing to do.
And of course, if you're listening to us or watching us from around the world, go. Thank you both very much for joining us on the podcast. It's been a lot of fun.